You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for professionals. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and an LLS volunteer. I want to thank all of you so much for joining us on this episode. Today, we'll be discussing compassion fatigue and burnout among healthcare professionals and the impact that this has on both personal well-being and patient care. We'll also discuss practical strategies for prevention, resilience building, and creating a supportive workplace and work culture. Today, we're delighted to be joined by Dr. Guy Maytal, who is the Chief Medical Officer at Forge Health and a clinical assistant professor of psychiatry at the Weill Cornell Memorial College in New York Medical College. And Guy, thanks for joining us.
It's a pleasure, Ken, truly.
So, it's interesting in day-to-day work, which is very, very busy and fast-paced and full of intellectual and emotional challenges. Sometimes there's not a lot of time to think about the issue of our own personal well-being. And yet, over the course of weeks and months and years, I'm sure in many ways it takes a toll that we don't think about. Teach us a little bit about these issues of compassion fatigue and burnout and how they're similar and how they're different.
Gladly. So we can start with burnout and move on to compassion fatigue. They are related but distinct. The thing I like to say about both of them and the common cause is in order to burn out, you first have to be on fire. And these experiences, syndromes, happen to people who are deeply passionate and caring about their work. People who are mission driven as clinicians, doctors, nurses, and others who take care of blood cancers or other disorders are almost uniformly. And compassion fatigue, sometimes it's called the cost of caring. To each individual patient, you are their only clinician, but you've got hundreds. And how do you bring the same degree of empathy, compassion, presence of being again and again and again and again? And that experience over time can take a toll for some people because it's exhausting, it's eroding to bring that degree of presence of being and intentionality. That's often what's meant by compassion fatigue. In the clinical literature, sometimes it's called secondary traumatic stress. Burnout is different. Burnout is due to workplace stress. Burnout can happen in lots of settings, but it is most often in situations where people are mission driven, but feel that the demands on them exceed their ability to engage, exceed their resources. So that is a chronic and insidious experience that happens. It involves emotional exhaustion. It involves depersonalization. The cynicism that is often seen in medical settings or the detachment that we sometimes see in ourselves or colleagues from our work, that's a cardinal indication of burnout. And then just a sense of reduced accomplishment. I feel like I'm just can't get it all done. So that's the quick and dirty on those two phenomena.
By the way, I have not heard the expression before, you have to be on fire first.
Yeah.
And thank you. I actually really appreciate that, and it makes a lot of sense. Let's focus for a couple minutes on compassion fatigue. So let me ask you to develop that same attachment to each patient. Can we? And in fact, what do you see as some strategies that may not be actually thought out as strategies, but how do clinicians like you, like me, like others, navigate that on a day-to-day basis in either healthy or unhealthy ways?
Yeah. So with compassion fatigue, you can't draw water from an empty well.
Got it.
We often listen, the open secret is we like some patients more than others. But that doesn't
True.
mean we can't be as effective clinically with everybody. The challenge is that the workload can be so much that I like to say I'd rather be my first patient of the day than my last patient of the day,
Yeah,
because
yeah.
I'm fresh, I'm ready for the day, I've had some coffee or some other good food, I'm ready to start things and bright eyed and bushy tailed. And by the end of the day, I have to really watch the exhaustion that's there. And you never want to be the last patient between the doctor and lunch or the doctor at the end of the day. Yeah, this is kind of stuff that we shouldn't say. So for us as people who are providing care, watching for that is really important. And having kind of compassion for ourselves, that's a very human reaction. It's going to be there. There's nothing wrong with it. You're not a bad professional for having those feelings. It's much more, okay, I have to make sure that I'm taking care of myself in ways big and in ways small. So during the day, it might mean I take a 5 minute break and walk around and go outside or look out a window or talk to a colleague or just something to restore myself and remind myself why I do this. And that's a big part of it in between, not just during the day, but in between. Reminding yourself why you do this is so important. And at the same time, it's important to do things like you set boundaries, which is really hard to do for many of us. Meaning, at the end of the day, you're done, which is really hard to do. I'm not saying this is easy. But one of the indicators of compassion fatigue is you keep thinking about patients in a way that you would rather not. Like they keep coming to mind and over again. And what about this? And what happened with that? And the opposite is equally true. When you just avoid them, like you see the person on your list for the day and you hope that they don't show up. That's a pretty good indication that you might not have enough, to go back to the same metaphor, water in the well for that particular person. So, okay, this person's coming to the well. How do I provide what they need? And then in between, like in your life, making sure that you are nourished in other ways. So often we neglect ourselves. It was particularly obvious during the pandemic when there were such relentless demands on everyone's emotional capacities and intellectual efforts. And during the pandemic, I was working almost exclusively virtually and seeing person after person. I take care of a lot of people as a psychiatrist who have cancer. And so, really grappling with, do I risk being exposed to a potentially life threatening virus in order to get treatment? Or do I forego treatment to stay safe from a potentially life threatening virus? I mean, the people were in impossible situations. And then how do I make sure I'm taken care of so that I can keep sitting with these impossible situations? So at the end of the day, I'm done. And then I go exercise, or I see friends, or I meditate, or I take a walk, or I cook a good meal, or whatever it is that's required for me to do that.
So, by the way, I'm going to share just a microcosm of that. But I had been in a group practice with three other oncologists. And one of my colleagues, at the time, I didn't think it was odd, but I thought it was not usual. But no matter what was happening and how sick people were and how crazy busy our office was, would always sit down and eat lunch.
Yes.
And whatever time it took him, and it was deliberate. And now, in retrospect, it was brilliant, I guess.
I can't agree more. It's absolutely brilliant. Just a brilliant maneuver.
I'm sure you've seen clinicians like this, but for me as an oncologist, as I walk through the clinic or I'm seeing colleagues, what would that clinician look like who's really at that point of compassion fatigue? And what would they sound like?
They would sound like they'd be complaining about patients. You know, we all complain from time to time, but uncharacteristically so. Someone who's usually neutral or positive about their work all of a sudden is complaining about this patient or that patient or the demands from this one or that family member. Someone who is more irritable, who is constantly on the lookout for the next task, technically hyper vigilant, like what's next, what's next, what's next, what's next, or someone who is really profoundly impacted by the stories. And we're all impacted by the stories of our patients. But you'll see someone who is dejected, demoralized by one or more of the patient experiences that they've had to engage with that day or the previous day. So someone who is, and frankly, there's no precise way to say it, but someone who just looks tired. And the trouble with picking up on all those signs is often we're experiencing some of them ourselves. So if someone complains, you're like, yeah, what else is new? Well, maybe there's something to address there. Maybe there's something to ask about. The trouble is, everyone is busy.
Yes.
And at the same time, I'll just add one thing that's already a pretty useful intervention is like you were saying about that colleague who took time for lunch. Maybe it was 15 minutes, but it looked like an eternity in a busy practice. It's okay to take a colleague aside and just for 5 minutes say, you look a little tired, or is everything okay? Anything you just want to get off your chest for 2 minutes. That will make someone's day that a human being noticed. Because many of us in this business, we're a bit self-sacrificial. This is kind of like if the shoe fits, we'll take care of ourselves last.
Yes.
So it's such a gift when someone else says, "How are you?" and means it. And it's small, but it's so impactful.
It reminds me of family, families and caregivers are sort of the forgotten people in the room.
Yes,
And when I or colleagues address them to the husband, John, how are you doing? And I've been a husband in that situation. But yeah, it's this tremendous sense of calm and thankfulness that someone took that extra minute. So it's a good point with our colleagues.
absolutely. And another way to say it, what you just said so beautifully, is it leaves someone with the experience of being seen.
Yeah, exactly.
So, very powerful experience.
Let's move on and talk some about burnout, which I got the impression as you were talking earlier is sometimes related to a clinician's environment, to the
Yes,
system they work
yes,
in, to the insurance demands, et cetera,
yes.
documentation. Yeah, say more if you would.
I'll say a couple of things about it. So, in the world of the biggest possible 30,000-foot view of the world of stress, stress is not necessarily a bad thing. There's good stress. In fact, there's a technical term, it's called eustress, EU stress, which is the kind of stress that's motivating, where the challenge that calls you forth to be because, yep, it might stretch me, but I can do it. And when I'm engaged in it, it's fulfilling and it's enlivening and it's rewarding and I'm proud of it at the end of the day. Whether or not I accomplished it, I'm like, I did a good job today. That's not going to cause burnout. That's for people who are passionate, who are excited, who are mission driven. That's going to have them get up and come back. A different kind of stress is it's an environment where you're asked to do things or have the experience of being demanded of in a way that exceeds your ability to do so or the resources at your disposal. In other words, the simplest way to say it is you feel that you have no control. And then you're asked to do things. So things like being given more to do than the time in which you have to do it and no say about it. Burnout's associated with things like administrative burden, caseload per day, staffing inadequacies or inequities. So, all of those things are associated with burnout. And it's not surprising, actually, the rates of burnout are actually higher in nurses than in doctors. I mean, they're high in both. Pre-pandemic, it was rough for oncology providers. It was roughly 50-ish% in many studies, many surveys. Post-pandemic, it's anywhere from 30 to 70%. And burnout, it's a syndrome, or there's a trio of symptoms that go along with it that distinguish it. One is emotionally exhausted, like you just feel drained and tired emotionally, physically, all the time. The other is what's called depersonalization. It's when you are detached from your work. Sometimes it's cynicism. And the third is kind of no matter what I do, I'm never accomplished. Like the reduced sense of personal accomplishment. So I feel ineffective and incompetent all the time, like no matter what. And those three tend to travel together. And that's what the technical definition is of burnout. And it's pretty impactful.
It would now be very difficult to have one's full presence and compassion and to provide that to multiple patients each day when you're feeling upset about. I mean, I'll give some examples, needing to close the quote unquote encounter and generate all the proper forms and set up the proper appointments. When, at least for myself, I thought, geez, you know what? When I was in practice, I could have someone at the front desk do a lot of that and not be able to change it.
Absolutely. I mean, it's all of the above. It's dealing with insurance companies. It's the experience of most physicians over the last several decades is a significant erosion in their autonomy in practice. Like, I just don't have as much control over my day-to-day life. I'm told what to do, when to do it. And then I'm asked to do things that are like too many patients in the time that I'm allotted to do a good job. I'm sure that's a very common experience that people have. And then, of course, we wind up having wait. So most doctors are often, quote unquote, behind in their schedule, or they're double or even triple booked. And then the patients are irritable because I've been waiting for an hour. And then all of the administrative, the documentation, which now it's all computerized, which in a sense, I'll say something that may not be so. I mean, in a sense, EMRs were supposed to make life easier for doctors. And in fact, they've made it more burdensome because the
Yeah.
EMRs, frankly, are tailored around billing and regulatory requirements, not so much the ease of documentation.
Yep.
So all of that puts together creates an environment where cynicism is rampant. And I feel like nobody goes into medicine, certainly no one goes into oncology to be cynical. It's always striking and even heartbreaking because I teach medical students around ethics and professionalism, and they come back with examples of, if they've seen an attending say something that they found kind of off or even shocking, and they start to criticize that person. I say, that person sat in your chair not that long ago. So the question is, how did
Yes.
you get from where you are to that person? And what could you do to mitigate that? Because that person is out to take great care of people. That is a person who wakes up, goes to sleep thinking about how to take care of people, and yet is dealing with these burdens.
Yeah, yeah. Well, let me ask you that question because you're right. In fact, when I hear patients complain, let's say about another clinician, and I'll typically say, Dr. So and so or that nurse, we wake up in the morning wanting to do good.
Yeah.
So, yeah, how does one go from that state of idealism, let's say as a medical student or intern, to cynicism? And even more so, what are some ways to avoid that?
Yeah. I think that the answer to how you go from idealism to cynicism is a really complicated one. For me, it's a story of one of those Shakespearean or Greek tragedies. 'Cause nobody starts off that way, and then some people wind up that way. It has to do with all of the things that we were talking about. It also has to do with, I mean, we could talk at length about it. It has to do with the economics of medicine. It has to do with the hierarchical structure of medicine, which is quite rigid during training. So it's hard to say to an attending who may be saying something cynical or a senior resident who is engaging in dark humor to say, hey, I'm uncomfortable with that. So we go along to get along. And then at some point we find ourselves, I just wound up here somewhere. If the only models we have are this, I'll go along to get along, then it's tougher to maintain one's own sense of idealism. I'm not saying it's impossible. There are plenty of doctors who are phenomenal and not burnt out. And I don't want to paint this kind of super grim picture, but this is a real thing to deal with. Now, the other side is how do you keep that from happening or reduce the risk of it happening? I think of it in the same way as I think about like maintaining a healthy diet and exercise regimen. Our society isn't designed for us to be fit. Our society is designed for us to be inert and eat poorly. So that's the kind of the design.
Yes, you're right. You're right.
I mean, there's nothing controversial about that. It's kind of like everything is designed to be remote control and instant gratification from my seat. So if I'm
Yes.
going to eat well and be fit, it requires intentionality and rigor and practice.
Yep.
And it's kind of the same here. And I wish more of this was taught earlier on in people's careers because, on the one hand, you could say, well, it shouldn't be this way. And maybe, I mean, in an ideal world, Probably, but here we are. This is what we've got. The question is, who are you going to be about it? And people say, well, it shouldn't have to. I'm like, well, you shouldn't have to think about what you put in your mouth either. But if you want to be fit and healthy, you do.
Yeah, you do.
It's like, what's the conversational and moral diet that I'm going to be consuming? So it's things like, I have to be intentional. I just love that story about your colleague who took lunch every day. I just think that's so brilliant.
Yeah,
It's
yeah.
so
Thank you.
brilliant.
I am picturing his smiling face right now. And I guess I should take it more as an example.
Well, the practice is really around our issues of self care and building what's called emotional resilience. Resilience is the property of a physical object to bounce back from some change. So, in the world of human relations, but self care strategies, I mean, listen, I'm not saying this is easy, but you have to be intentional and, frankly, at times go against the grain when you say things, I'm going to take a break. And people around you might say, well, we have all this work to do. And in oncology, it's all the more challenging because I think of a phrase of, well, don't you know they have cancer? And the response is, but all of our patients have cancer.
Yeah, yeah,
And so things like eating healthy, taking time to, I'm going to say a forbidden word, to exercise. And the thing about exercise is any movement is better than nothing. My dad is also a doctor. He's one of the people from whom I've learned quite a bit about how to keep the cynicism at bay. He had a rule like less than 4 flights, he takes the stairs. They still practice. He's in his 70s. He practices full time and less than 4 flights takes the stairs. Something like that. Whatever works for people. For some people, it's taking a walk. For some people, it's walking the dog. For some people, it's talking with a friend. Whatever it is to take care of yourself. And in terms of the emotional resilience, it's having a peer network that you can count on friends, family, colleagues. It's really being what I was saying earlier, like, eating well and exercising, it requires discipline, rigor, and practice. Like, you have to, whatever it is that you do to take care of yourself, you have to keep it as one of the things that you do. Otherwise, you know, the default is you eat junk food and don't move. That's the default. So the default is you'll see around you what the default is. And there's nothing wrong with it. It's just that you may not want to participate in it in that way.
got it. I keep thinking to myself about the word report card keeps coming up in my mind. So since you're a psychiatrist, I guess I'm allowed to, I'll free associate a little bit and just use it. But if you were to give in a sense, looking at sort of the subspecialties or the different parts of medicine, how do we in oncology, in terms of self-care and resilience, is all of this individual or is it sort of, are some trends that you've seen in different parts of medicine in terms of self-care, resilience, all of that?
Yeah, I'll separate those two. I think it's really challenging for oncologists because self care is not something that we're good at
Right.
in oncology. We're just not, because this may come back to bite me. But I think of oncologists as like the helicopter parents of the medical world. They're completely appropriately, but like so, oncologists are deeply engaged in the
Hmm.
medical world of their patients. And many oncologists I know don't ever take a vacation. I mean, they go
Yeah.
away, but they don't take a vacation.
Yeah.
They're available all the time to their patients, which, if I'm a patient, is extraordinary.
Yeah.
I want to be that doctor's patient. Truly. I may not want
True.
to be that doctor's child or
Yes.
spouse. I think I'm not offering anything proscriptive. This isn't like this is good or bad, but it is the reality that oncology has to contend with, that we are all often, frequently, if not always, available to patients in oncology. And it's hard to take care of yourself in that setting for some people. And there's no generalizations here, but I think in terms of self care, it's a really tough thing when, don't you know they have cancer? I have to be available.
One of the things that's a day-to-day issue in oncology is I'll use the word truth telling even today and this morning prior to talking with you, but I really was talking with two patients who were getting closer to the end of life. And there is the issue of truth telling. How much
Yes.
do I say? How do I say it?
Yes.
What are your thoughts on that?
I think this is where I speak with all due humility because I don't have those conversations on a regular basis. I hear about them from patients of mine. So I'll be very humble in what I'm about to say, but I think that oncology as a field provides insufficient training for those conversations. I think that somehow you're supposed to absorb it from mentors when you're in training or colleagues when you're out of training
Yes.
who did the same. They absorbed it from mentors in college. So at some point, it becomes this recursive phenomenon, but there is so much now known and available to train yourself, both to take care of yourself in those very challenging conversations and in the mechanics of them. How do you do it in a way that's less frightening and more effective? For example, I think if the goal is to not upset people, you're doomed to fail every time.
Correct. Yeah.
I think if the goal is to learn how to be okay with people's being upset, then that's something that's achievable. I think that a lot of doctors get upset that they have caused upset for their patients,
Yep. Yep.
which is very human, appropriate, and somehow at the same time, when you step back from it, a little bit irrational because we live in a culture that frequently denies the fact that we're going to die. And yet, all of us are going to die. And often oncologists are the people who bring that conversation from the background to the foreground for people who don't want to engage with it, but kind of have to. And it's a very tough situation for anybody. And it's even tougher if you have to do it multiple times a week or even a day. Talk about a situation where compassion fatigue is likely to arise. So there's lots
Right.
of training out there. Not that oncologists have
Yeah.
time for
Yeah.
it. I mean, that's the irony, of course. But taking the time to invest in that is specifically around, okay, how do I communicate in the way where I'm not so impacted by their upset? Which is very different than how do I say the right thing so as not to upset them.
Yeah. Thank you. Guy, we've talked a lot about burnout, compassion fatigue. We've talked some about sort of self care. I really took to heart what you were saying about really asking colleagues, or at least expressing interest, the how are you? But let me ask about institutions also. What do you see as some ways that institutions can have a positive impact on these issues?
Yeah, so a couple of thoughts. One is I think that the first step is institutions need to look at it from an institutional level or a systemic level. Given how prevalent burnout is, we have to tell the truth that the system now operates in a way that it's predictably burning people out in the field. It's not an exception to the rule, it is the rule. So if it is the rule, then we have to look at it at this level of system. All too often, individuals are asked to address it at that level, but you can't solve a systemic issue at the level of individual. You can only survive it. So that's where we find ourselves. So the first step is the institution has to be willing to say there's something systemic going on, and we need to think about how to address it systemically. And of course, from the doctor, nurse, other clinical perspectives, well, the answer will be give me less patients, more time, and more money, which of course is not going to be a common answer that they're going to get. So the question is, how do you figure out ways to do it? I mean, there are lots of things institutions could do. Some of them are pretty low hanging in terms of fruit. You know, giving people some more flexibility around scheduling. Anything that gives people autonomy in their day-to-day work life is going to reduce the risk or intensity of burnout. Any way you can reduce administrative burden is going to be helpful to people. Any way you can create care that is team-based, because I think in a lot of clinical care, it's, and I don't mean team-based like a slogan, I mean like actual team approaches to care, so that all too often it's like I'm the only one who's carrying the burden or the responsibility of caring for these patients and I'm on my own. Or it's how productive are you, individual being? I'll say those three letters, RVUs. If you're measuring people individual productivity, then the person's going to be focused on the individual's work. You could do things like there are innovative approaches around how do I measure team productivity? And then all of a sudden the solutions to issues aren't only at the level of individual. Where are there efficiencies that I can find in the way we work together? And the last one I'll stop because I want to hear what you're thinking. One is, when leadership simply acknowledges the problem and shares their own challenges in addressing it, that's like you were saying earlier, just asking a colleague, how are you? I think sometimes leadership wants to pretend like it's not happening or to sugarcoat things. And everyone in the crowd listening goes, what are you talking about? Things are pretty horrible. And if you have the sort of leadership who can say, yeah, things are really challenging. We know that we're not clear how to address it, but we'll work with you. My goodness, that's a very different type of culture in an institution. And that leads to the last thing, which is having any sort of peer support mechanisms where people can feel that they're not alone is incredibly useful, whether it's support groups or sponsored lunches where you don't talk about medical stuff. There are things, a lot of institutions have Schwartz rounds, which are incredibly useful because you can talk about the non-technical, non-medical aspects of clinical care with colleagues in a multidisciplinary way, and you're fed. So you're taken care of in multiple domains in that hour. So I'll stop there. Those are kind of the big things that institutions could do. There are certainly others, but those are the big things.
So again, it's Dr. Ken Miller. I want to first say thank you. This has been a great discussion, and I want to thank Dr. Guy Maytel. Guy, thanks again.
Truly a pleasure and an honor, Ken. Thank you very much.
And along those lines, I want to thank all of you for listening to this terrific episode. For a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, please visit lls.org/CE. And for any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources. And this is available in English and Spanish. LLS also provides other resources for patients, survivors, and their families, and can be found at lls.org/support. And I encourage you to sign up to receive notifications of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page. And we look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society, and access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.